So we've done a bit of work at Grattan, 3 reports on quality and safety, and we also, of course, did the Targeting Zero report a couple of years ago. I'd just like to follow up that last question. If I have an operation, if I need a hip replacement, for example, when it comes to the consent process, it seems to me that the hospital I go to should be able to say to me, you're a 45-year-old, a man, you have diabetes. For a person like you, these, in our hospital, over the last 12 months, these are the adverse events that occurred here. And for a person like you, when they were asked, was your pain relieved, 85% said it was relieved 3 months after surgery. We can do that now, or rather, except for the Oxford Hip Score measurement of your hip pain or whatever, we can do that now. We have those data right now. And it seems to me that it's this personalisation to the patient's experience that we need to be going towards. And the clinical quality registers can do that. And one of the benefits to patients is to make them understand not only the likelihood of benefit, but also the risks that they are incurring in a way which is so relevant to them. So I've been asked to talk about the change and what we can do more. And I'd like to start by using this, which is my petal diagram. The whole object of policy is to achieve change in the behaviours of individuals, of groups, of institutions, and professions and so on. And we have a number of ways in which we can try and influence those behaviours. We can influence those behaviours through rhetoric, we can influence those behaviours through provision of information. There's a number of ways in which we can achieve those behaviours, those changes. But what I want to do is to look through, since Targeting Zero, how have we gone on that? And by and large, we made a set of recommendations about organisational changes, governance changes and so on. The creation of Safer Care Victoria, the creation of, we didn't use that name, VAHI, we didn't use that name either. But that's basically happened. And so we have seen a change of the infrastructure, and the objective, what we were trying to achieve with that, incidentally, amongst other things, was to try and change the culture, try and change the way we think, trying to change the resources. So the governance changes, the organisational changes have occurred, and I think are well on the way to doing what we thought they should do. But what I've also targeted here is not that we're also trying to think about new skills, and to some extent we've done that. That is, Safer Care Victoria does do the training of new skills and so on, but there is still quite a way to go, but it's a tick. We were very keen to change the rhetoric. Basically, in Targeting Zero, what we found was the department focused primarily on finance, and there was almost no rhetoric, almost no discussion, almost no visibility of the importance of safety and quality. And so Safer Care Victoria has done something like that. Whoops. There's something else I'll come on rhetoric in a minute. We also said simultaneously we want change in the rules and regulations, and in particular there was a change to the Victorian Health Services Act. It said, in the past, it said health services provided by healthcare agencies are of high quality. That's one of the objectives of the Act. Now it's much more specific. The objective of the Act include that healthcare agencies provide safe, patient-centred and appropriate health services and foster conditions for the improvement in the quality and safety of the care and health services they provide. Much, much more specific. So we're changing the context within which the regulation of health agencies in this state occurs. And in particular, we're fostering continuous improvement. So the rhetoric, the mandate, the objectives enshrined in the Act have been changed to signal this is important and this is what you should be doing. However, we've still got to mind the gap. And there's a big gap, obviously, between what's in the Act and actually what happens on the ground. So by and large, we've got these ticks. about things that are happening and about things that are going well. We've also got feedback, and this is principally the responsibility of the Victorian Agency for Health and Innovation, and Lance will be speaking to you this afternoon, immediately after me or sometime after me. And again, this is about changing the very way in which agencies perform. So if you, 4 years ago, when we did the review, we went around and talked to health services, and many of them said, yep, we've got good information. I remember having a meeting with the chief executives of all of the metropolitan health services, public health services in Melbourne, and we said, one of the problems we have now is we don't know how our performance is, what our safety and quality performance is. This was early in our review. I was slapped down and said, look, one of them said to me, look, the health department doesn't know what the performance is, but we know what our performance is. We are able to measure safety and quality of healthcare. So I was busy writing the report, and I wrote a phrase that was in the draft report, which one of our full-time people said that when she read it, she choked on her coffee and splattered it all over the keyboard. And my two colleagues on the report, on the committee, they suggested it wasn't one that should see the light of day. I thought it was one of my better phrasing. It was that the chief executives or the health services were wallowing in their own self-congratulatory ignorance. So I thought it was pretty good. And the reason I said that is because they could track their own performance over time. They had the historical data of their own health service. They had not a clue whether their performance was improving at a faster rate or a better rate than everybody else's. So they did know something. They could see them improving, but they had no idea whether that improvement meant they were going from the front of the pack to the back of the pack. And so I'm very strongly of the view that we need to have not only the information about how you perform against yourself, and that's important, but how you're going against everybody else, because everybody else is improving at the same time or at different rates. So we're now getting much better at that. We're now providing information. And as I think Sally said, part of it is, I'm very strongly of the view that we should have private reporting before public reporting. We should actually make sure people have the ability to look at their data themselves and do the improvements before we move to public reporting. I'm also in favour of public reporting, of course, but it's in its order. And here are some examples of what can now be done. This is a real health service in Melbourne where they are able to measure their various complications that they've got in their hospital, but they can also, it is also now possible to see how they compare with the statewide distribution and where their distribution of complications, adverse events, is different from the state. So this then signals where you need to look. And any of the examples of routine data do not tell you anything about this is a problem. It just says this is where you need to look. And it's that next step of where you need to look that is the important issue. Here's another one we suggested in one of our reports, again looking at the different sorts of complications and having best and worst, how you are comparative to everybody else. Again, it's all about telling you where to look. And we've got the power of these data now that are helping us and ought to help us in driving improvement. Again, another one from one of our reports where we looked at 3 hospitals, imaginatively called Hospital A, B and C, and we looked at, these are hip replacements actually, and we looked at the comparative rates, and there's Hospital A down here with a very low rate of additional of adverse complications, Hospital C with a very high rate, and Hospital B where they do well for people under 74 but don't do well for people over 75. And so again, you've got, if you're in this hospital, you've got a big problem for all of your patients, but in this hospital, the problem is probably not a surgical one. The problem is probably an issue about rehabilitation and post-acute care and and how you're linking with your geriatric services. So it helps you identify where you should look and what your problem should be. This is another one about the use of information. This is again from one of our reports. This is Safer Care Saves Money, where we looked at, we can estimate the cost of complications in a hospital. In this particular case, these are the 20 biggest public hospitals in the country, where we looked at the cost of complications, the additional costs that a complication occurs. As you know, if there's a complication of care, it adds to the length of stay, adds to the cost of treatment and so on. So we estimated the cost of treatment in those hospitals, and we compared it with the extra revenue they got, because in many cases they get extra revenue because the DRG payment changes as they move into a higher DRG. But in every case, if you draw a line from here to here, the extra cost was greater than the extra revenue they get. And so there was a business case for quality. That is, not only does safer care is better for the patients because of reduced complications, reduced risk and so on, but safer care is better for the bottom line of the hospital. So it is possible to develop a business case, and this ratio, it's about 2.5 to 3 times more cost than revenue. So clinicians can actually start to go to the management of the hospital and say, you know, we've been talking on all the time about how good doing something about quality improvement is for patients, and you've never been listening to us. Well, hello, I can now speak your language. It saves money as well. And so you can develop a business case. This is our Whipples procedure example. The College of Surgeons responded to this by writing a paper saying we're wrong, which may be true, but basically these were the hospitals in Victoria which were doing Whipples procedure. The evidence in the international literature was that hospitals that do fewer than 10 of these a year have higher complication rates. And you see a whole lot of hospitals down here which have fewer than 10 patients in each of 2013 and 2014. This is from our Targeting Zero report. I'd have to say, even despite the College of Surgeons' response to this and looking at this specifically, if I were fronting up in Hospital L, I'm not sure I'd like to be the only one of these they'd done over a 2-year period. I would be much more comfortable going to one of these hospitals where the team, not only the surgeon, the lead surgeon, the team is used to the procedure. Incidentally, this is not a rural-urban issue. Of the 20 hospitals that did fewer than 10, only 4 were rural. That is, 16 of them were metropolitan hospitals. This is the HIP. These data are from the Joint Registry, one of the good registries. Again, this is about whether we know from the registry which hip prostheses are more likely to be associated with revisions. And so you can actually then say, well, to what extent does an orthopaedic surgeon choose prostheses which are in the 10 best performing prostheses? And by and large, and we group them, or the registry grouped them into those that are actually only use 2 prostheses regularly, 90% of the time. They use 2, 70-90% of the time. They use 2 less than 70% of the time. But all 3 groups generally don't only choose from the best 10 prosthesis combinations. And again, if you're a patient, you'd like to be actually going to a surgeon who uses, I think you'd like to be going to a surgeon who commonly uses the same prosthesis combination sets and also chooses those which are from the best performing combinations. Now, the way the registry phrases this, it is that if you're an average performer, these are the results. But of course, top performing orthopaedic surgeons might not use the top performing prostheses, but still get top performing results. Another issue about quality that we haven't talked about much is about appropriateness of care. And in this study, these are studies done at the University of Sydney in Adam Elshaw's group. They looked at the indications for 4 different procedures, and looked at the likelihood that these procedures were low value care. That is, the likelihood that the indications just weren't there. And they had different ways of estimating it, narrow estimates and broader estimates, and they looked at both for public and for private. And you can see in every case, there's more likely to be low value care in private services, private hospitals, than there are in public hospitals. But in both cases, there's a lot of low value care going on, which means there's care which probably doesn't return a benefit to the patient on average. So again, we have a question about to what extent should that sort of thing be on the agenda of our quality and safety. But anyway, so what I'm showing you there is we're doing a lot on feedback, a lot on information provision, and so we should give a tick there on achieving change in quality performance. The elephant in the room is whether we're doing enough and whether we're addressing things like appropriateness. We've got financial incentives, and there's a financial incentive from the Commonwealth to all states collectively about hospital-acquired complications. I said, Lance, I wasn't going to talk about this, but I am briefly going to talk about it. The incentive is essentially on sentinel events and what are called designated hospital-acquired complications, a list developed by the Safety and Quality Commission that the Safety and Quality Commission says is one thing and the Minister says is another. But putting that aside, it's not the main game. It actually only addresses a small proportion of the overall adverse events that take place in hospitals. However, the actual evidence about whether financial incentive works at all is quite weak internationally. So even though we've done a bit on that, I'm not sure it's going to be much use. We haven't done anything much at all about consumer education and empowerment. The Safer Care Victoria has a consumer education, consumer empowerment, consumer engagement group, but I still think that this is an area where there's a lot more that can be done. We've done very little with all of these things together are starting to try and change the culture, but I still think we've got a long way to go on improving the culture of quality improvement and the engagement and so on. I think there've been great strides since we published Targeting Zero, but still further to go. And I'd like to just finish by saying the importance of culture is immense. It's about the leadership of organisations, it's about the CEO, the boards, showing that quality absolutely is imperative. It's one of the things that drive the organisation. And in my view, I was at a meeting a couple of days ago and my argument was that the amount of time spent on quality and the amount of time spent on finance should be roughly equal if we're trying to actually be serious about sending these signals. I'll skip the RCA stuff. But as I said, there's a lot of good rhetoric, there's a lot of changes to the systems, to the governance, to the financial incentives and providing the information, but the gap between what is best practice and what is not best practice is still huge. Someone said to me recently that, look, in Victoria right now, we have some of the best quality services in the world providing care. In Victoria right now, we have some of the best quality services in the world. The trouble is, they're not everywhere. So we've got the best somewhere, but we don't have the best everywhere. And that's what we should be looking for. Thank you very much.